Okay, friends. So today is a big day. We have with us Dr. Alessandro Castana, and our today's topic is slap tear. Uh, this subject has been debated and been always been quoted in many controversies, starting from the etiology to diagnosis to the management and the current concepts, which has gone through the lot of efforts. And we have three eminent speakers for today's webinar. Dr. Sagar Kakatkar, he is the upcoming arthroscopy surgeon from Nashik, and he has done many fellowships in shoulder arthroscopy. So he's going to enlighten us some anatomy and biomechanics. Then we have Dr. Nagaraj Shetty will be joining us in short time, and he is going to speaking on the pros and cons in management. And then the final word is going to come from Dr. Alessandro Castana, who is going to elaborate where are we today in the concept of management of slap repair as far as the shoulder practice is concerned. So without any delay, I will like to request all our panelists and the speakers for the day that we will start today's program. So we have moderators in the form of Dr. Rajkumar Amaravati, Dr. Swanendu Samanta, and Dr. Abhay Narvekar. He'll be joining shortly. So, and the panelists are Dr. Alex Castana again, then Sanjay Trivedi will be joining shortly, Dr. Nicholas Sentau, Bhupesh Karthik, P. Jayaprasad, so, Vivek Pandey, Deepak Joshi, and Shirish Pathak and Sivin Surendran. So with this, I will hand over the moderation for the session to Dr. Rajkumar. Rajkumar, can you take over from here for introduction of each speaker and discussion after each lecture?
Yeah. Thank you, Roshan, and it's been a pleasure to host the eminent speakers for this session on slap tears. Without wasting much time, I would call upon Dr. Sagar Kakatkar to tell us something about the history, the anatomy, and the biomechanics of slap lesions. Over to you, Sagar.
Thank you, sir. And good evening, everybody.
Yes, good evening.
I'll be sharing my screen, sir. I hope it's visible now.
It is visible.
Yeah.
Make it large.
Thank you. So at the outset, I would like to thank Roshan sir and Arthroscopic Study Group for giving me this opportunity. I'm actually thrilled to have a meeting with Professor Alessandro. I have been a huge follower of his technique of anatomical slap repairs. So today my job will be to discuss the anatomy, biomechanics, and the history of the slap tears. So in 1985, Andrews et al. Had discussed the slap lesion anatomy in athletes, after which Professor Snyder actually was the one who coined the slap tear as the name. The slap complexity or the anatomy of slap complex can be divided broadly into anatomy of the labrum and the anatomy of the biceps attachment. So if we see the anatomy of the superior labrum is much like a meniscus, like a structure in which the free edge or the articular side is floating free. It's not firmly anchored to the glenoid. In contrast to the inferior labrum, which is firmly adherent to the glenoid cartilage. And because of that, we do have a few normal variants, anatomical variants, such as a sublabral recess or a foramen and buffered complex. Sublabral recess is often misdiagnosed as slap tears by our radiologist friends, but we can easily differentiate it as it is a smoother structure and usually the depth is less than 3 millimeters. So if we also see our slap tears, when we do arthroscopy, it is always better to go under and see how the biceps attachment is. So if we could appreciate almost all of these, the biceps will have attachment to the labrum, that is superior labrum, but most of the part will go back at the supraglenoid tubercle. So there has been a lot of debate about attachment or the origin of the long head of biceps. And it is basically from three parts: the supraglenoid tubercle in almost 40 to 60% of the patients or cases, the posterior superior labrum, in few of the patients, the intertubercular circles as well. This is an interesting study coming from India, Indore. In 2018, it was published in the Journal of Anatomical Society. They have described a new attachment of the origin of the biceps, that is the bicipital tubercle of the scapula is what they have coined it. If we see on the left side, the arrow, the yellow arrow which is pointing the area, it is the area labeled as the bicipital tubercle of the scapula, and it is more posterior and medial to the supraglenoid tubercle, which has been marked by the red arrow. So this was a cadaveric study, an interesting one, which also showed that the long head of biceps attachment is actually going slightly posteriorly and medially. This was a superior lamina or superficial lamina which was getting attached to this bicipital tubercle of the scapula. But as a rule, if we see, the biceps tendon basically goes back medially and slightly posteriorly and is not getting attached exactly at 12 o'clock position. One also has to appreciate a contribution from glenohumeral ligaments when we are considering the anatomy of slap complex. So the anterior-superior labrum does have contributions not only from the superior glenohumeral ligaments or the middle glenohumeral ligaments, but also, if we appreciate, the IGHL also contributes a lot in formation of the anterior-superior labrum. In fact, we had an interesting paper published in 2005 by Yamamoto, Eiji Ito et al. They had described and classified the macroscopic and microscopic features of the long head of the biceps attachment of the slap complex. Basically, the macroscopic anatomy was divided into three types. A posterior type in which the biceps was going down macroscopically and getting attached posteriorly completely. A posterior dominant type, an equal type in which the biceps was seen slightly getting attached in the middle of the anteroposterior labrum. But if we see the histological studies which they had done, which is a very interesting part, the orientation of the long head of biceps tendon fibers in all three parts was always and always posterior. It was never coming in the anterior part of the labrum. And in fact, it was the contribution from the IGHL, SGHL, and in equal type, you can see middle glenohumeral ligament as well. So the contribution of the glenohumeral ligaments was the one which made it appear as if there was attachment on the middle or anterior side on the superior labrum. So the bicep always remained posteriorly, and it was an apparent macroscopic viewing which led to conception of the anterior type or equal type biceps attachment, and that was all because of the glenohumeral ligament contribution. Blood supply to the slap complex hasn't been studied extensively. There are only few papers regarding it. This was one of the recent article published in 2017, and it's an excellent article. And as we all know, most of the blood supply for the labrum is coming from the periosteal blood vessels and the capsular blood vessels. But surprisingly, there is hardly any contribution from underlying glenoid bone for the blood supply. So we have been doing debridement and trying to get blood supply from the underlying glenoid bone when we are reattaching the slap complex. But mind you, when we are having knowledge of the anatomy of the blood supply, it is something very surprising. Most of the periosteal blood supply is from the ascending glenoid artery, which you can see on the right side of the image. Ascending glenoid artery is actually a branch of axillary artery, most often second part of the axillary artery. So labrum is nicely vascularized. Most of the labral vascularity, as also seen in the meniscus, is mainly in the periphery. The superior labral complex is actually having not much of a blood supply. There are only a few radial penetrating vessels which are also in the periphery, but it has a very good sympathetic and sensory innervation at the biceps anchor site. So that makes slap tears a painful condition. But if we also consider this from a surgical point of view, Just imagine a patient with labral vascularity and neurological supply coming all the way from the capsular side, and if we just tighten and strangulate the biceps labral complex by simple sutures on anterior and posterior side, that might lead to a restricted range as well as failure to have a union of the labral or healing of the labrum properly. So if we have to appreciate the complexity of biomechanics of slap complex, I think we have to ponder around the development or the evolution of human shoulder. It all started from the Carboniferous period when first reptiles appeared. So fins were converted to shoulder girdle, and then we had development of the coracoid. It was first called metacoracoid, where the conjoint tendon was seen attached. The conjoint tendon and coracoid lie in these earlier reptiles was lying in line with the axis of the humerus, and it was functioning for the propelment of the body of these reptiles. Slowly, the primates developed, and with the development of primates, the biceps divided into two parts. That is a short and long head of biceps. In the earlier primates, or even we can see on the left side, like this is a gibbon. So those animals who are pronograde, that is walking on four limbs, they have the shoulders or the anterior part or anterior limbs closer to each other. So they have broader tuberosities, and the long head of the biceps is sitting exactly on the ventral surface of the humerus. So as long as the biceps is functioning in the ventral surface of the humerus, it acts as a restraint for anterior-posterior translation. So biceps in these uh, animals acts as anterior stabilizer. So, and if you consider animals which are actually suspending along the branches, such as orangutan on the right side, you can see the glenoid morphology and the humerus morphology is quite similar to what we have in humans. That is, the biceps has shifted along with the bicipital groove on the medial side. The humerus has some rotation for the upper limbs to reach the midline. The lesser tuberosity is slightly shorter in size because of the biceps shifting. So the biceps and bicipital tuberosity is medialized in these forms. Similarly, a wonderful study done by Eiichi Itoi, published in 1996, studied biomechanics. And on the right side figure, you could see that in case of internal rotation of the shoulder girdle, the biceps was even further medialized and it did not act functionally as an anterior restraint. The middle figure shows a neutral position, still biceps slightly medialized. But if you have an externally rotated shoulder that is almost 30 degree or more than that, the long head of biceps becomes a ventral force which can act as a depressor and can prevent anteroposterior translation and also a torsional restraint. There are certain studies which will promote and say that biceps of the slap complex acts as a glenohumeral stabilizer. We have a lot many of them, just mentioning a few. Few of these studies, all of these were cadaveric studies, and few even mentioned that after creating a type 2 slap-like lesion, they had noticed anterior translation as much as 7.5 millimeters. This was a study published by Burkhardt et al. And inferior translation of 4.7 millimeters, which is quite significant. But the problem with these studies, I feel, is the angle at which these shoulders were tested was far less than 90 degrees or even 60 degrees. And the other thing is, all of these studies, if we consider the methodology, they had completely detached the slap complex from the glenoid, which is rarely a situation in our regular patients. If we see the biceps anchor and glenohumeral stability other papers, one of the very good papers comes from Rodowski et al., which was published in 1994. And it was a dynamic study, was tested in 90 degrees of abduction and 70 degrees of external rotation. That is a late cocking phase of a thrower. And it did show that the shoulders which had long head of biceps could withstand the external rotation force in a better way than the shoulders which were lacking or which had a type 2 slap tear created by periosteal elevation. It also showed that a slap tear always and always increased the stress on the anterior limb of the IGHL, which can give rise to the anterior instability. There are controversial papers also, like this one published in 2008 from Thomas Yom et al., which showed that at 90 degrees of abduction and external rotation, there was hardly any glomerular anteroposterior translation and rotational increase after they had created a slab type 2 tear. So we have to agree that the data itself is slightly controversial considering the biomechanics of slab complex, but it is definite that if you overstrain or if you are over tightening the slab complex while repairing, there are increased chances that you will sustain that shoulder to tighter external rotation force. And the last part, if we consider the history and mechanism, how it happens, there are only three ways a slap injury can happen. It's a traction injury, compression injury, or a direct injury. A wonderful paper again by Gary Kurtzman and Muffet, which showed that if a patient has a sudden inferiorly directed force, such as if two people are lifting heavy weight and suddenly one of them just gives away and leaves the weight, the other person suffers a sudden inferiorly directed force, which can lead to a slap tear. It is also seen in deceleration phase of the throwers, while a more common way of injuring yourself, at least in India, I feel, is falling on outstretched hand with your shoulder in abduction and flexion, well documented by Snyder et al. It is basically due to two mechanisms. One is it is because of pinching of the superior labrum between the humerus and the glenoid, and secondary is the strong reflex contraction of biceps and cuff due to a traction injury. There have been different mechanisms and different classifications according to the type of injury. We can have a thesis on that. It's a huge topic. But apart from that, this was all for the history and mechanism of injury from my side. Thanks a lot for this opportunity again.
Yes, wonderful talk, Sagar. You did touch on every aspect of anatomy, the biomechanics, and pathology. I just wanted to have a question regarding that IGTO study, which you said. Dr. Freddy Fu study, which was published in 1994, where they had tested a requirement of bicep in abduction external rotation and late throwing mechanism. Was it a operative study or was it? I didn't get the details of that study.
The biomechanical study you were saying, sir?
Yeah, the one which is published by Freddy Fu. Rodowski and Freddy Fu.
Yeah, so it was a dynamic cadaveric study, sir. It had basically the biggest change for that study was they had pneumatic cylinders attached, and they tried to mimic forces which are equal to the rotator cuff forces and long head of biceps force in a normal thrower. And they tried to imitate the same finding using a pneumatic cylinders on the anatomical models or the cadaveric models. And then they tried and they divided the shoulders into classes, that is one without slap and other with slap injuries. And accordingly, they tested it.
Okay. Any other question to Dr. Sagar?
Yeah. Roshan, can I ask a question?
Yes, Dr. Anta, yes, please go ahead.
Sagar, congratulations.
Thank you, sir. Nice to see
you.
So
proud of you.
Thank you, sir.
Sagar, you showed a nice study, mechanical study in features. Can you tell us more about our sport, cricket injuries in internal rotation?
So the basic abduction and external rotation for the throwers, even in cricketers, remains the same. I think so. In our cricketers, they don't throw the ball with that much of force. So the type of injury which our people usually have is not because of deceleration, is what we see. So the kind of injuries they have is because of probably hinging of the superior labrum between the humeral head and glenoid. Also, most of our people or the sportsmen have definitive scapulothoracic dyskinesis, which is a major contributing factor for this. Again, the labrum getting crushed between the humerus and the glenoid, rather than a classical traction injury. The pictures which was described, microtrauma leading to attritional injury to the superior labrum in pitchers. We don't see that injury in our cricketers, at least, is what I feel in my experience.
Thank you.
Thank you, sir.
Next question.
Yes, please go ahead. Who is this?
Yeah, Shital here.
Sheetal, yes, please.
Sagar, very nice presentation. The cadaveric study that you have shown from the anatomical department, which shows that the attachment of biceps is more on the posteromedial side. So I think, can we have a clinical implication of that thing, that the slap type 2B is more important rather than type 2A? And fixing 2B is more necessary as compared to 2A.
Yes, sir. Sir, in the details, I could not mention because of the time restraint. The study mentions that actually the attachment of long head of biceps is in a lamellated fashion, and there are two different bundles. So the deeper bundle, which is a thicker and a stronger bundle, always gets attached to the supraglenar tubercle and the labrum, while a thinner bundle goes at the back of the glenoid and getting attached to the bicipital tubercle. It actually gives, if we see, being more posterior and medial, it gives more anatomical and biomechanical advantage, because then the biceps, which is at the angle of 30 degrees, becomes horizontal. So it's actually acting as a better restraint for the translation. So probably we can't say, but it might be a one change, that is, we are evolving for the evolving, and we might see the attachments getting posterior and posterior. But yeah, like you said, probably type 2 test getting more symptomatic and fixing that posterior part more often makes a sense if we consider that attachment.
Yes,
Roshan.
Yes, Milind.
Yeah, Sagar, congratulations. It's a wonderful presentation. Yeah.
Thank you, sir.
I think the most important issue here is the cadaveric study done by E.G. Itoy regarding the role of superior labrum in anterior instability. So they have done that wonderful cadaver study where they have very categorically mentioned that the SGHL, which also has got an attachment to the superior labrum, the slap, that is the superior labral complex, and the anterior capsule, they play a great role in anterior stability of the shoulder. And that is why we have started shrinking the capsule anteriorly as well. They also have shown that if this slap remains for a long-standing period, then these patients, they develop anterior instability, and they also can develop cartilage lesions just below the cuff. So antero-inferior or antero-superior part of the humeral head will develop cartilage irregularities there. And as regards Antav's questions, there are fast bowlers as well. Before the throwing phase of the ball, their shoulders, they also do go into abduction and external rotation. So the cocking phase, whether it be a baseball, whether it be a cricket, the mechanism remains the same. So I would tend to agree that the mechanism of slap is also a traction in fast bowlers. That was just a comment. Thank you.
If you see the screen, there is a kinetic chain concept. Sagar, sorry, I'm just
yes,
trying
sir.
to.
Sorry. Yeah.
Milind, do you want to elaborate on this? The kinetic chain concept?
So kinetic chain actually is a concept given by Ben Kibler. And the concept is that no fruitful movement occurs at a single joint. So to have strength in the shoulder, you need to have a good core strength as well. So for a fast bowler or for a pitcher who's pitching the baseball, the strength actually derives from the core as well. And all those patients or all those athletes who have a poor core and have a scapular dyskinesia will try to generate force through the glenohumeral joint because it is not aided by the core strength of that particular athlete. A simple example which can be given is if you try to throw a ball standing in a swimming tank, the strength which is generated is less than what you can generate while standing on the ground. So this kinetic chain plays a very important role in shoulder kinematics. And if the kinetic chain is poor, that is why all these patients of shoulder, slap, anterior instability, cuff, whatever, the kinetic chain needs to be addressed in the rehab program. And before you really take slap surgeries, you should assess the core and as far as possible, try and improve the core as we do it in ACL surgeries in a prehabilitation phase.
Dr. Alessandro Castagna has raised his hand and I think he has a comment. But before that, I want to ask Dr. Alessandro Castagna himself. biomechanically the slab gets attached on the supraglenoid tubercle or maybe little anterior to the glenoid aspect, which has been recently described. So it has got some amount of traction mobility in vertical direction. And how does it compensate when it comes to the anterior instability of the shoulder? Does it contribute greatly to the anterior stability, or it is just a misnomer? Alex.
Well, yeah, the point is that, first of all, Sagar, congratulations, a great presentation. The perfect
Thank you, sir.
You did a great job. But now, of course, we are talking about something that, number one, most of the studies that you reported properly are cadaveric studies. When we are speaking about an anatomy and the biomechanics of a joint like the shoulder, where anatomical variation are so common. So if you go to the book and then we check what we observed during our surgical experience, 1 out of 2 has some differences of what is typically described. This includes the complex of the labrum, you mentioned the Buford, you mentioned the sublabral hole, blah, blah, and many other things. So it's very difficult to make a direct transfer of the data that we achieve with the cadaveric study to the real role of a slap lesion to the biomechanics. And I totally agree also with the colleague of the core stability that is crucial, that cannot be considered when we do a cadaveric studies. So of course, we are learning very much by these studies, but translation directly from the cadaveric to the real life cannot be so automatic. There are some solid points regarding the anatomy, and I like the superior tubercle. You will see later. You will see later in my presentation. So we need to keep everything in mind, but we cannot think that white is white and black is black, because it is not the way. So this is the only thing, the comment I wanted to do. But you did a perfect review about this, and it was very interesting about also the blood supply, because the superior labrum, I mean the articular side of the labrum, is very poorly supplied by blood, and it is very true that it is coming much more from the periosteum and the capsule itself. So in fact, it doesn't heal on the articular face when you go back for a second view. So I enjoyed this very much, but we need to keep that the data that many studies are reporting, they are important to us, but they are not giving an answer that is considering the 360 degrees of the joint mobility and stability, the shoulder, because it is very much related to many other factors that are not included in a simple, let's say, simple cadaveric studies. This was my comment.
There is a difference between throwing mechanism, and this scapula body axis ratio has played a very great important role when you define the shoulder instability, and especially the structure like bicep, which is a dynamic stabilizer only in the tension mode. It is not in static mode. It is not a stabilizer. When you have a tension mode, patient is trying to throw, somebody is trying to throw, and that is a time when it has got a stabilizing factor. So it's very important that whenever you do consider the bicep lesion, you have to consider the superior labrum as a more stabilizing structure than the bicep. In fact, that is where it comes nowadays, that you do a bicep tenotomy and do a superior labral repair as well. Because I feel the stability to anterior shoulder joint is a very, very dynamic stability imparted by the bicep tendon. Any difference of opinion on this, Dr. Alex, Dr. Milind, or Swanendu?
Well, I totally agree. And again, you will see I'm at risk of repeating the same concept that I will describe in a few minutes. That but the principle is that we put under the same name different condition. So slap lesion is not just slap lesion, and let's assume that we are talking about a slap 2 lesion. We are simply talking about a superior labral detachment that may involve eventually the superior glenohumeral ligament, the middle glenohumeral ligament, that is not the biceps itself the issue, or just the superior labrum. So we are talking about something that is much more sophisticated and complicated. Is
I
it
think
my feeling?
I think Roshan, the picture that you showed the just now, how the change of core or the position of the pelvis and the hip changes the scapular axis and the biceps mechanism. That is the real story behind the change in core. I cannot accept more of what my friend Milin told, because of the change in the core in the hip and pelvis, even in the foot, the course of the scapular plane changes, and that is the basic mechanism of the change in axis of the biceps, and that impinges internally, and that is the basis of your having this scapularly your supraglenoid strain of the biceps, and that is the beginning of your anterior and posterior capsular lesion. So if I can understood from the early and your cocking phase.
Roshan, I have a question for Dr. Kakatkar.
Saranendu?
Yes, sir.
Yes.
Rajkumar, you want to go ahead with the question? Go ahead.
Sorry sir, मैं आप थोड़ा पहले आ गया बस.
कोई बात नहीं.
Agar, congratulations for a wonderful presentation. I understand the anatomy changes with the way we evolve, and also the attachments move from one point to another point as we dissect out the cadaver. Now, when we see the anatomical way that we repair these labrum or the slap lesions, do you suggest that we put a particular tension in the way it has to come, or it doesn't really reflect on the way we put the tension on the repairs that you do, or does it influence the biomechanics?
Thank you, sir, for the question. I think so, sir, with the kind of attachment variations we have and all of the studies, one point was very consistent that most of the biceps complex or the biceps anchor attachment is on the posterior side and it's on the medial aspect of the glenoid surface. So I do, as I said, I do follow Professor Alex anatomical repair technique because it consists of a medialized labral repair and it's a you don't take any simple suture on the posterior aspect. So basically you pass two limbs of a suture posteriorly and then tighten the posterior aspect and just take a simple single suture on the anterior aspect. So we have to medially repair that part posteriorly. That is the most important part while repairing the slap anatomically. Also, I just forgot to add one slide. If I'm allowed to show one slide, sir. I'll show we have been studying and discussing this dynamic change of the part or the dynamic stabilizers of the shoulder and the slap. What is one important study which has been shown in 2019, it was published. It also considered the static forces which are responsible for slap injuries. A wonderful study studied importance of critical shoulder angle. How a lower critical shoulder angle, as we know, it has been known to cause a medially directed force because of the deltoid. Lesser critical shoulder angles can lead to a slap tear, probably because of hitching of the superior labrum. So just wanted to show that the static or the bony architecture also can add up in formation of the slap tears.
Okay. If there are no questions for Sagar, thank you very much, Sagar, for a wonderful presentation. That was a really eye-opener. In fact, we never heard of this better presentation on blood supply and attachment of bicep labral complex.
Milind sir had a question, Roshan. Milind sir had a question. Dr. Milind had a question for Dr. Kakatkar, I think.
But Milind is not there on screen. Is he there?
He was there and then...
Okay.
This is Milind is there. Milind is there.
Yeah.
Milind, yes, Milind, go ahead.
Sir, no. Question.
No, Swaranendu, the core is actually from the multifidi and the external obliques. So the core strength doesn't come from pelvis. Although what you said is absolutely right, that whenever you are thinking of a kinetic chain, you should start thinking from the foot position. So when you analyze a shoulder patient as a whole, if you are going to consider core strength as one of the major factors for the shoulder condition, then you have to start analyzing patient right from his feet. So what you say is absolutely right, but then the core doesn't come from pelvis. the pelvis needs to be square, and the squared pelvis will remain only because of the anterior and the posterior hip muscle equilibrium. Whereas core strength relates to multifidi, that is the small muscle of the spine, and the external obliques. So it's basically external obliques anteriorly with the recti and posteriorly balanced by multifidi, which will give rise to a core strength. And that is why we do planks to improve the core strength here. So analysis as a whole of the kinetic chain and with more focus onto the core strength.
Yeah.
That was I just wanted to put it across.
Yeah,
Thank you,
completely
Milind.
agreed on that. Yeah.
Yeah. Thank you, Milind. I think we should move on. Rajkumar.
Anecdotally, I would want to add what Milind was telling. We lost a medal in the Rio Olympics because of the same reason. Our shuttler had a very poor core. Though she was a star shuttler for the country, she had to come back with injury early. I just want to add this. I don't want to name the shuttler, but she had to come back with the injury early because of poor core.
Yeah.
Next talk, Roshan, if you can have.
Yes, please. I'll request Dr. Nagaraj to share his screen. Nagaraj is going to speak on pros and cons and what are the technical difficulties in the bicep tenodesis and slap repair and his algorithm. Nagaraj.
Thank you, Dr. Roshan. Thank you, the Academy members, for this opportunity. Greetings from Mumbai to Dr. Alex Castania. It's an honor to have him on board, and congratulations, Sagar, for the nice talk. Can you all see my screen, please?
Yes.
Okay, so I have just modified the topic. It's mainly a technical topic with a few insights into what I have learned about this pathology over the years and how I approach it, what we could call it as a treatment algorithm of this pathology. I'm not going to talk much about anatomy and the classification because that has already been very well covered. Just a few tips and tricks as to how the etiopathogenesis impacts our decision making. I'll stress upon that. I'll share my tips and tricks as to what presently are my techniques for slap repair and when I actually go for a biceps tenodesis. What are the best practices? What are the best instruments, etc. we need to have in RKT? A little bit of literature review and the conclusions with the algorithm. So we have very well discussed about slap lesions in terms of the biceps labrum junction, and we all know the history behind it. There's no need to go into this. Stephen Snyder proposed this with the repair techniques initially, and then we all knew that we were overdoing the slap repairs, especially the type 2 slap repairs. And now we are all wise enough to understand that there are only a few indications for doing a primary slap repair, and that the patients have to be selected very judiciously. We all know about type 2A, B, and C. We have been discussing that in detail. And we now know that we need to stabilize the biceps labrum complex in patients in whom they have unstable biceps labrum complex contributing to pain primarily, and secondarily to stability, as Dr. Roshan was mentioning. This is a no-brainer. Whenever we encounter a type 3 slap with a bucket handle flap, we know that we need to preserve as much as labral tissue as possible, restore the stability of the biceps labrum junction. And this may or may not be in association with instability, that is posterior inferior labral tears or anterior inferior labral tears. It could be an isolated pathology too. But more often than not, it is usually an extension of the instability scenario. We all have seen the situation of type 5 and type 6 slaps, where they are extension of these various pathologies. For the beginners or for any youngsters who are there, it's very important to know the two normal variations. Do not confuse them with labral tears in the area of the superior glenoid. One is a sublabral foramen, which is just like a hole under the MGHL. Do not think of it as a tear and try to repair that defect. That is anteriorly. This is the Buford complex. Do not go ahead and repair this. This is again a normal variation present just anterior to the biceps labrum junction. It's a cord-like middle glenohumeral ligament. It is actually like a thick cord which runs from the subscapularis and inserts directly onto the biceps labrum complex. And these patients also do not have an anterior superior labrum. So don't think of this as an avulsed labrum and try to fix it anteriorly there. Don't do that. Patients will have refractory stiffness and pain. We do encounter even in younger patients in their third or fourth decade with degenerative kind of slaps where there is significant amount of fraying in the superior labrum. We clearly know that this is not amenable to repair. And the question is whether we leave it at tenotomy or we do a tenodesis. They may or may not be associated with the cuff pathology, significant cuff pathology. It's a no-brainer that if it's a patient with a low demand, patient in whom, because of the bulk, the popoid deformity is not a concern, you can go ahead with a tenotomy straight away. We all know that we need to do what is called as a funnel tenotomy. This is just the way I do it. I don't use a radiofrequency wand. I use a kind of a scissor, and I try to take a funnel shape, some amount of the superior labrum along with the biceps, which creates this funnel shape, and it creates a autotenodesis because the biceps remains stuck in the groove and there is no popoid deformity. We have gone into detail in this. Broadly, we all would agree that either it's a single traumatic event, meaning the patient gives a particular history of a sudden fall on outstretched hand or a forceful abduction external rotation. I have seen quite a few patients in my practice who have had an abduction external rotation injury. These are typical the gym goers. So there is a single traumatic event which they may or may not recollect, and such events on repetitive occasions have also made them have this pathology. Repetitive microtrauma in our cases is not as classically seen as in the baseball players, but we do see in the overhead athletes, whether they are racket players, whether they are cricketers, we do see this phenomenon of repeated microtrauma and the peel back mechanism. And I will show you a couple of videos which I have encountered in my practice who have had this repair successfully. So we need to keep in mind that these are the two broad categories, that is a black and a white, but there are a lot of gray zone, meaning a avid gym goer also can have this sort of an injury. I have seen people now who are into mixed martial arts, who are into doing headstands, etc., who also can have these sudden jerks and they damage that labrum, and over a period of time, it starts manifesting itself. So there is a black single major traumatic event, there is a white, which is repetitive microtrauma in an athlete, and there are a lot of gray areas in the middle which we need to look at. This is one summary I have to say over the practice that I have had over the years. We know about the traction theory. We know about the peel back mechanism. We know about the concept of GIRD and internal impingement. Just to reiterate, that is something we all need to look at. That is the initial thing that happens in these athletes is that in the hope of getting excessive external rotation, they develop a tightness of their posterior capsule, which causes the humeral head to go up, which causes the internal impingement. That is, the superior labrum gets pinched between the superior glenoid and the humeral head along with the articular surface of the cuff. So the classic triad being that there is a superior labral tear, there's an articular surface tear, there may or may not be subchondral cysts. We need to look at these in detail in our MRIs, and clinically we need to check for posterior capsular tightness and restricted internal rotation and abduction called as GIRD. We all know these tests, but what actually helps in my practice is the O'Brien's test. This is a case which classically shows that. So she's got severe pain, and that pain gets relieved when the palm faces up. So this has got a diagnostic value in my practice. The compression rotation test also helps. What's more important is these patients invariably do have some amount of restriction of internal rotation. So that's an affected arm. And she's got significant amount of internal rotation on a normal arm. So we always keep working on these, the posterior capsular tightness. We work on the scapula. Obviously, the patient comes in the OR only if they have failed conservative treatment, only if we are very sure that the pain source is from the biceps labrum junction. We have talked about restoring the kinetic chain. We have talked about getting the core strength. We know that we need to correct the posterior capsular tightness. We know that we need to do extensive scapular rehab to make sure that the pain is actually coming from the biceps labrum junction and not from the other factors before we ever decide to go for surgery. Now, what is the cons of operating on this patient? We all have burnt our hands. If you diagnose them inappropriately, if you repair them such inappropriate cases, they land up with consistent pain. They are painful for a prolonged duration of time, one of the most frustrated patients to have, and they can go around town, giving a bad name to this particular surgery. So you need to be very careful that that is the primary take-home message, that these are not the cases you can decide without appropriate rehab, without thorough evaluation, and with appropriate imaging. Broadly, we know type 1 is to be conserved. Type 2, when we are sure that this is the source of the pain, you can do repair when the labrum is of good quality. As you saw one of the videos, a young patient having significant amount of degeneration in the longus of the biceps, you would then do a tenodesis. And when you encounter it with instability scenario, it will be part of your instability surgery. When the biceps is significantly affected, theoretically, yes, less than 50% affection, you do have the option of repairing them. But lately, I would tilt in towards doing a biceps tenodesis when in doubt, when the biceps itself is the pathology. And that would be the second and last part of this discussion as to what are the tricks I follow for doing a biceps tenodesis. Again, the question remains, when do you repair? Broadly, younger patients, when they have failed good rehabilitation program, they have a definite history of trauma, or a definite history where I feel that there is a biceps labrum instability. These are the cases where you would then go ahead with repair. Associated cuff pathology, I would say that there are quite a few patients who do have combination of labral tears with cuff pathology, and that would be a relative contraindication. Generally, initial decade of about a decade back, we saw many papers coming with good outcomes of slap repairs, and these are younger patients with overhead athletes. But there were equal number of papers which said that the patients could not return to their pre-injury status, and there was adequate number of reports coming, especially from the European surgeons, Pascal Bolo, etc., who convinced us to go for tenodesis, and there was no role for slap repair in their practices. We discussed about the blood supply in detail. So what's the problem with the repair? If you do not select your patients judiciously, obviously you run the risk of over constraining them. If you do not follow the principles of surgery, which I'm going to show in a couple of videos, you are likely to not cause healing of that particular tissue. You're likely to create over constraint. You're likely to plicate some amount of capsule, causing refractory stiffness. Most importantly, if you put bulky knots, which otherwise in other areas of the glenoid you don't need to bother, you can cause knot irritation, aberration. You can cause what is called as a squeaking shoulder. So every time the patient does rotations and abduction, there is a squeaking sound that comes, and there is cartilage damage. And this predisposes to a biomechanically poor outcome. And if you don't treat the coexistent pathologies, for example, if there is a cuff pathology and you don't treat it. This is actually a video from Neil Eltrash, where he has shown the impingement of the knotted anchors. And this is one of the well-known videos which made us believe that we should go for the knotless anchors. And that's the impingement of the knot on the undersurface of the articular surface of the cuff. So the summary is to go for knotless anchors as one of the options for labral repairs in the superior equator, in the upper equator. So this could be an intraoperative dilemma. Is this a slap tear or is this a meniscoid labrum? Is this a peel back kind of a mechanism? So this is very much a normal variation. We need to understand that this is a meniscoid labrum. Do not fix these sort of lesions. And this is not exactly a peel back mechanism. This is a true type 2 slap. These are the ones where there is you can see there is a reddish discoloration there. The cartilage appears to be bruised. And these are the kind of cases where the biceps labrum junction is unstable and you need to repair these. Just a quick tip for the youngsters who are going to be doing this. This is your go-to portal, the port of Wilmington or the slap portal. You take about 1.5 to 2 centimeter lateral and anterior to the posterolateral corner of the acromion. That's where the port of Wilmington will appear in the left shoulder, and that's in the right shoulder. This is an intraoperative video of how we need to go ahead with it. Now, what's important to understand is try to come in the muscular portion of the cuff. So no, don't go there near the rotator cable. Come in the muscular portion of the cuff, and it gives you direct access to that area. So that's the port of Wilmington. That's how you can put a small cannula in that. There is absolutely nothing to worry as long as you put a small cannula and predominantly in the muscular portion of the cuff. And this is the video that I wanted to share. This is a patient who suffered with shoulder pain for almost a year. He has had multiple rehab sessions, but he could not get relieved of his pain. His pain was appearing to be coming from the biceps labrum junction. We did not have conclusive evidence on our radiological investigations. Because of the extensive suffering that he had, we decided to go ahead and evaluate his biceps labrum junction. He's not an athlete. He's not an overhead athlete. He is an avid gym goer. He cannot recollect a specific event, but he says something might have happened a year back. And this is his evaluation. I always evaluate the anterior and the anterior inferior labrum thoroughly, even if I know it's a slap tear. I have seen diagonal opposite lesions in some cases. So this is his superior labrum, which on cursory examination appears normal, but it allows the probe to go in. This could be a peel back mechanism. So that is making the biceps labrum junction unstable. And as I get the liberator just slips inside, revealing that particular lesion. So we saw a classic type 2, we saw a concealed lesion. What's important to know is you need to prepare the glenoid thoroughly. So I use this sort of a torpedo shaver blade or a flyer blade, which nicely goes into that particular area. The blunt conical portion protects your labrum, and then you can debride the superior labrum, get it to bleeding bone, because all efforts have to be taken, number one, to make sure this heals so that the biceps labrum junction is stable. Number two, you do not want to over constrain this. You don't want to plicate it. You don't want to tension it too much. So that's on the left hand side, the prepared rough surface and the bone. On the right hand side, you can see, yes, this is a knotted anchor. I have now also started using knotted anchors, low profile anchors like the all suture anchors, making sure that the knot comes on the capsular side and it is a low profile knot. I do like to use this percutaneous kit. That's another tip which I would like to share. It has made life very easy. So this is a short video of how we go about using the percutaneous kit and the knotless anchors. So you prepare it with the labrum, you come with your torpedo shaver blade, prepare the bone, you then come with a low profile device. I do not use the bird beak. I use a low profile device like the Spectrum or the AccuPass, and then just pass it only through the labrum. Do not take capsular part. Sometimes you will see that the labrum and the capsule are adherent to each other. I actually release it with the radio frequency to make sure I don't plicate any capsule. This is a knotless construct, so I'm using a suture tape. This is the percutaneous kit. So the spinal needle comes in. Through the spinal needle, you can put a nitinol wire. Through the nitinol wire, you can dilate it with a cannulated Wissinger rod. And through that, you can actually put a small percutaneous cannula, which allows you to come with the drill bit for the knotless anchor. You come onto the prepared raw surface. You don't come onto the face of the glenoid because you don't want to over tension this particular area. You just remain subchondral. You load it to the knotless construct and you create a low tension but firm repair, making sure that the biceps labrum junction becomes stable. The knots are cut flush and you have this nice low profile, low tension, stable repair. That's how it should look, the capsule nicely away. With these principles, you can be sure that you will have good outcomes. This is the patient's follow-up. He is actually a avid gym goer and he is back in his gym. So slap repair is done in younger patients. You tend to be very stringent with your clinical and arthroscopic diagnostic cannula. You have the option of using knotless and percutaneous construct. You need to counsel the patient that in spite of being very sure, it will take a long rehabilitation for him to get relieved of his pain in the range of 6 months to 1 year. And quickly going to biceps tenodesis, when I'm sure that the biceps labrum junction is unhealthy, and it's a low demand patient, I go for the percutaneous intratendinous tenodesis technique described by Mark Rodofsky. So this is for low demand patients who do not want a popoy. 2 spinal needles coming in. We shuttle the sutures in a cruciate fashion. These needles are coming in the rotator interval area. So you take an echelon through one of the needles, you take an echelon through another needle, and then you shuttle an ultra braid. And in a cruciate fashion, you shuttle a co-braid. These sutures are then retrieved in the subacromial space and tied, and you cut the biceps at the biceps labrum junction. So that's the pit technique, which works very well for patients who are low demand. You don't need to do any anchor-based technique, but the patient gets relieved of the popoy also. You then do the biceps tenotomy and suture these cruciate sutures in the subacromial space. So that's the pit technique. We all are aware of the suture anchor technique. I use the lasso loop technique. So you use one of the sutures, make a lasso out of it. You can use double loaded anchors, you can use triple loaded anchors, and you can use the, so that's the lasso loop being created. That's the tenodesis of the biceps in the subacromial space. The last case that I'd like to present is this patient who is again a gym goer. He presented actually with a full thickness biceps tear, and the biceps was actually, as you can read here, that it was not visualized in the groove. We got a sonography done just prior to surgery, and it had retracted significantly all the way down. This was his preoperative popoid deformity. Now, these are the cases, and even the cases who are high demand, where I would go for a subpectoral tenodesis. So we saw a percutaneous technique, we saw anchor-based technique, which we routinely do when we have a cuff pathology, or even otherwise we can do it with an anchor in the suprapectoral area. In the subpectoral area, we need to go with a mini open technique. So this is a technique-based presentation. That's his popoid deformity. He also had a cuff tear, so we did his cuff repair first, and then we take an incision. We place the arm in abduction and slight internal rotation, and that makes the pec major tendon prominent. We take the incision along the long head of the biceps. The interval is between the pec major and the conjoint tendon. With this information, so that's the incision along the long head of the biceps, that's the pec major and the conjoint tendon. The clavipectoral fascia will be incised. The short head of the biceps basically would be retracted inferiorly, and the pec major would be retracted superiorly. You need to then identify the long head of the biceps in that groove. You need to put some tension in order to snap it out. These are the techniques where you actually create a tunnel and put a screw, but these have got risks, and it is very intimidating to put a 8 mm tunnel in this particular area. And I have gone away from that. So that's this particular patient. So incision along the long head of the biceps, identification of the clavipectoral fascia, identification of the pec major insertion. You dissect between the pec major and the short head of the biceps. You place a spike such that the spike retracts your pec major, and then another retractor which protects the short head of the biceps. Once you have identified the biceps tendon, you need to snap it out. You then identify the pseudo tendon. In this case, he had a significant amount of pseudo tendon which was resected. You then take about 2 centimeters of healthy tendon from the musculotendinous junction. So you can see the spike retracting the pec major. My finger is always identifying the biceps groove and protecting me from going medially. That's the only important thing to remember. You know, there is the musculocutaneous nerve medially, and we need to be careful about it. You then prepare it with cautery. You then prepare with periosteum and roughen that surface. So what I'm showing is the anchor-based technique. So knotless, all suture anchors is what we prefer. 2 and sometimes 3 in a triangular fashion. I then use the sleeve of the all suture anchor and do a kind of a shingling in that area to encourage the healing of that 2 centimeter of tissue onto that roughened groove of the biceps. Then the biceps anchor the all suture anchor has been placed. You then do the lockdown technique. So you start from about a centimeter point and go all the way up to the 2 centimeter point. You take multiple multiple Kessler type of stitches, and you do the lockdown technique. So when you pull on the free suture, the tendon gets docked into that roughened surface. This patient actually had such bad biceps that one of the sutures had cut through, but because I had used multiple anchors, I could retrieve the situation. So that's how we take the stitches. And I actually used a knot pusher to make sure that I don't over tension there. The arm is in about 30-degree flexion. In 30-degree flexion, you make sure that the anatomical point is reached so that you don't over constrain. So that's the knotting. That's the final repair of the tenodesed biceps tendon. That's his outcome. So that's about the summary of what I have understood over the years. I'm happy to answer questions from the elite faculty.
Thank you, Nagaraj. So paper is open for discussion. If anybody has any question.
Nagaraj?
Yeah,
Sheetal.
Specifically to the patient that you have shown, if the patient is having a GERD syndrome along with the slap, and you are taking the patient in OT for a slap repair, what interop thing you will do to correct his reduction of this internal rotation? You will do some kind of releases there, or you will just leave it like that?
Good observation, Sheetal, but that patient was not for slap repair. She was a patient who had some other pathology, but the videos were very good, so I used it for this presentation. I would make sure that the patient is prehabbed well. She has recovered her range of motion. I don't remember an occasion where I've done a slap repair and a posterior capsular release. But yes, if you are in a situation like that where you have been caught up, then you could do a posterior capsular release. But in my case, my patient would be prehabbed well. The GIRD is corrected. Only then he qualifies for surgery. So slap repair is not a surgery for me without thorough rehab.
Okay.
Okay. Any other question, Dr. Nagaraj?
Sheetal, sorry, Nagaraj, can I ask you?
Yes, sir.
Some question.
Pleasure.
Good evening. Nice and wonderful presentation, crisp and clear.
Thank you, sir.
What is your, I can say the tolerance limit to assess these slap lesions by clinical testing? How much importance do you give for clinical testing, or are there any situations that you are very sure that there is a slap lesion based on your clinical testing, and when you go inside, you are found wanting? Such things have happened for you, or is there something to learn from that?
Great question, and we all are trying to find out what would be the best combination of clinical testing, MRI reporting, and our experience over the years to be able to not get any surprises in intraop. So that's a very valid question. Now, what I've found helpful in my practice, in spite of its disadvantages, is the O'Brien's test. I agree there are disadvantages to it. It's a impingement position, so anybody with an impingement will have an O'Brien's positive. So a combination of a patient who has a history of trauma, who is otherwise a patient of repetitive microtrauma, like we discussed, if there is an O'Brien's positive, especially if it's relieved with the arm, with the supinated arm, it gives me a level of confidence that yes, there is a biceps labrum pathology. The compression rotation test has helped me. I've also found that usually these patients also have an apprehension. Somehow, I don't know why it is. It is probably because of the fact that you are loading that biceps labrum junction even when you're doing apprehension, because the entire biceps labrum junction is weak. So I don't think there is any use of the Speed's test or the Yergason's test. They are not very beneficial. So to summarize, O'Brien's relieved by the supination maneuver, compression rotation, anterior apprehension. These are probably the three tests, in addition with history. With a good radiologist, I've got a good team of radiologists who can diagnose these lesions thoroughly for me. Failed conservative treatment patient, with these criteria, I would go inside. Yes, there can be surprises in terms of having additional pathology. I've had patients who have had additional pathology. So there is a slap lesion and there is a diagonally opposite anterior inferior labral tear also. So after those particular experience, I'm very thorough in checking repeatedly the entire labral complex.
Nagaraj?
Yes, sir.
Along with the O'Brien's, as we all know that the sensitivity and specificity of O'Brien's is very low.
Yes.
So what I've started doing is, since you very rightly pointed out that it simulates the position of impingement, so I always add a Hawkins Kennedy to it. And if suppose Hawkins Kennedy is negative, but O'Brien's is positive, I think that gives me a little solace that probably I am diagnosing a slap tear rather than an impingement.
Okay.
So I think regarding shoulder, we should convey it across that no single test is panacea, and you need to really have a comprehensive approach towards evaluating patient MRI scans and multiple clinical tests to arrive at a plausible clinical diagnosis.
Correct. Absolutely.
Alex, I've got a question for you. do you ever suppose, even Nagaraj was telling the apprehension test, whatever we do in 90 position, like 90-degree abduction and external rotation, do you believe that whenever you test the patient at 90 degree of abduction and external rotate, do you feel the patients are apprehensive, or this is a indirect sign that probably you are dealing with this lab if the O'Brien is positive or whatever?
Dr. Alex Castagna.
Yeah.
This is a question for me. Well, taking it a little far away from this, for me, any clinical test is not giving me the guarantee that I have a SLAP lesion.
Yeah.
This is point number one. SLAP lesion is a suspect that I develop, asking the history of the patient, the symptoms, and the response to some rehabilitation. Plus the imaging, the clinical exam are leading me to suspect this, but not to be sure that I will have a SLAP lesion. So I don't have any suggestion for a very secure testing that is telling me, well, you have a SLAP lesion, because honestly, for me, SLAP lesion is confirmed during arthroscopy. And again, it is a little more sophisticated. Maybe I'm answering you in my presentation. It is a little more sophisticated because we speak about SLAP lesion, but I agree that some cases they have apprehension, pain like a subtle instability. They even, and I wrote this in arthroscopy years ago, about impingement syndrome signs. Many other signs can be associated because other pathological conditions can be associated to the superior labral detachment. This is the key point when we think about SLAP, because we are, let's say, cheating ourselves, giving one name to describe something that is anatomically, biomechanically, and clinically very, very variable. This is my point.
I think we should move on to the next and most important talk. Dr. Sibin and Dr. Bhupesh, I think we will take your questions after Dr. Alessandro Castana's talk, because we have very less time.
Yeah.
So,
because otherwise I'm repeating myself.
Yes. I think there are a lot of repetitions going to happen. So I'd like to request Dr. Alessandro Castana to start his presentation. Meanwhile, I'll just introduce Dr. Alessandro Castana to all these viewers. He has done his MBBS schooling from 1974 to 81 in the University of Roma. And then he had studied in Milan. He has done many fellowships. As far as his professional activities are concerned, he is involved in many of the academic activities, including ISACOS, the European Shoulder Society, the American Shoulder Society, and International Shoulder Society. He is organizing chairman and scientific chair of the International Shoulder Society meeting in Rome in 2013, 2023 in Rome. So over to you, Dr. Alessandro Castana, for your presentation on SLAP lesion revisited.
Thank you very much, Roshan, for the invitation, for this beautiful introduction. But what I like the most, I am simply a passionate guy about shoulder. Just a little memory. In 1990, I was doing my internal fellowship with Steve Snyder, the year he published the paper about it. So I know the history of the SLAP lesion, and I will make a quick review of it, because nothing is just frozen in the same position. 30 years ago, we were thinking about something that is now switching in my mind, although everything that happened before me or before us was important to develop today's thinking. So let's say it revisited. Why? This is where the history of the SLAP is starting, already mentioned very quickly. But Jimi Andrews in 1985 described it for the pitchers in baseball, and then Steve described in his classical paper the SLAP lesion as a tear of a superior labrum from anterior to posterior, leading to symptoms, clicking, and or instability. Remember this: symptoms of pain, clicking, and instability. So we have this tear of the superior labrum that is clinically significant. Then interesting. Don't miss also this other little part of my scenario and my mosaic when I started thinking about it. There are many associated lesions when you have a superior labral tear. You can have rotator cuff, you can have a Bankert, and so on and so on. It can be a little different about the age of the patient. So why the slap is symptomatic for the slap itself or something that is related to something else. This is leading to a great confusion in the last 2 or 3 decades about the treatment strategies. Somebody are saying, well, it is very effective. Some others are saying it doesn't make any difference if you don't treat it or if you simply make a biceps tenodesis or biceps repair. These are some of the strategies starting from 1990s up to more recent times, and every single author is giving it its own description, saying, well, you can just fix in some patient, you may leave this alone, you can treat the type 2 and leave it alone for the type 1, or the type 3 just regulate the bride labrum, and so on and so on. So there was a lot of confusion and a lot of techniques described about it. This is the typical Wilmington Porter that I think that was clearly described by Negre. And then the tenodesis, and Negre again described this very clearly. At the very end, some authors said, well, don't repair it, just make a tenodesis of the biceps. So we are assuming that the problem is the biceps. But I'm not sure about it after observing many of also my personal experience. The return to sport reported in the literature is very, let's say, anecdotal. It is from 4 to 6 months in most of the papers. Somebody is not reporting this, but anyways, the way they collected the data was not very, very scientific. This can be a good overview from the group of Tony Romeo about the possible option that we have in our hands when you have a slap lesion. You can do an arthroscopic repair in the young and active athletes younger than 35, or a laborer or military, very important in the US, or with some concurrent instabilities. So associated instability is part of it. You may take into consideration a biceps tenodesis for if you have a rotator cuff tear when the pulley is gone, and the pulley, when it is gone, you cannot repair it. So probably tenodesis can be an option, or if they are recreational, or after failure of physiotherapy. Finally, tenodesis or tenotomy, if you are French or some Italians, in the senior patient, when you have arthritis, when you have a certain specific patient that has pain for the biceps related to this. So the scenario is very confusing me. I don't have a single indication. I don't have a single pathology. I don't have nothing that is clearly defined to say, well, this is a slap, and I don't know it is before surgery, as I mentioned before. When I see it, sometimes I can find something else, and there are other aspects of the patient, the symptoms, and the activity that may lead me. Because at the end, where is the truth? What is a slap lesion? On top left, you see the 4 types described by Steve, but then Maffei, and this was reported before, even reached 9 different types when you have superior labrum, anterior, inferior, circumferential, and all around. And then you have so many variation of the biceps, as I described. These are on bottom right, the pictures of my classification. Sorry. Classification of the variants of the biceps structure in the joint. So what we are talking about with this slap lesion, one of the major benefits that we got from arthroscopy is a perfect visualization to really understand with the diagnosis where is the anatomy that is failing, and we can make something that is very much focused on the findings that we have. This is the major tool after Watanabe in 1957 described it. So now let's go, and I should say that Sagar reported a study about it, but it is the origin of the anatomy of the biceps attachment. This is Thomas Banksness of the UCLA in 1994. That means 30 years, almost 30 years ago. He dissected 105 cadaveric shoulder to study the origin of the tendon and the long head of the biceps. And what he observed, again, 30 years ago, it was just 4 years after the publication of Steve Snyder's paper, he described that in all specimens, approximately 50% disease matching the data reported by Sagar of the biceps tendon arose directly from the superior glenoid labrum with the remainder attached to the supraglenoid tubercle. So the attachment is not the labrum itself, it is something else. And look at this picture on the right. This is one of my cases that I treated, and it is very, very special that is teaching us so much. You see that we have, I don't know if you can see the arrow. Can you see my arrow? No? My pointer? Can you see my pointer?
Yes, we can.
Okay. So this is what should be the cable. Do you agree with this?
Yes.
And this is the biceps. We don't have any labrum. This is not a traumatic shoulder, just painful. No labrum. And you see that we have a significant part of the labrum, of the biceps that is attached where? Exactly superior and slightly posterior, as the studies described more recently. This picture was enlightening my mind. So the labrum is not the only issue when we repair the slab. We need to look somewhere else. So the historical repair, this is what I did for many years, strangling somehow the superior anchor with these two suture anchor. This is historical, you see, this is braided suture, ethibond with a metal anchor, and so on and so on. This is where we started to treat this. But then many papers came out. This is one of these many papers coming about the biomechanics of the superior labrum described by Sagar. We have attachment types of the long head of the biceps tendon to the glenoid labrum and relationship with the glenohumeral ligament. They were already mentioned by many of the speakers and during the discussion very properly about the glenohumeral ligaments related to the labrum and the anterior superior labrum, because this is involving the superior, the middle, and even the inferior glenohumeral ligament. So strangling the superior labrum is probably not the best solution. And I started thinking about it. This is 2011 paper on arthroscopy, and so 10 years ago, when I described shoulder painful without symptom of instability, and it was with the anterior superior labrum with no slap, no biceps anchor direct involvement. They were painful with this positive apprehension test with very much elevated, not 90 degrees, but maybe 110. And then in another paper, always in about shoulder, I described minor or occult shoulder instability and intra-articular pathology presenting with extra-articular subacromial impingement syndrome. Why is this happening? Stimulating my brain, the few still neurons that are still working. Because the shoulder is an interactive joint. It is a balance between the static and dynamic factors responsible of shoulder stability with the delicate balance. And the malfunction of any of one or many may lead to an overload of the structure. So it is exactly what we were discussing before about the core, the different ligaments, and so on. It is an interaction of many different elements. So anatomy matters, yes. I think yes, but we need to think anatomy not just very superficially, but more deeply. And this is my anatomical repair, one of the hundreds of the papers that describe different techniques for it, but it is the only one that is taking really into consideration the very true anatomy of the attachment of the superior, of the biceps. This is a series that I published probably 15 years ago or so. 2 years follow-up, blah, 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 good results, and so on, and so on, and so on. But where is the key point here about this technique? In this surgery, the mobility of the labrum, in my mind, in the articular face, should be preserved. We do not want to strangle it. because if we strangle the free margin, as other speakers before mentioned, we are really changing the biomechanics of the shoulder. We need to have this margin that must be free in the joint. And the risk of severe loss of rotation can be high if you are too aggressive in this position. Stiffness is one of the issues of many techniques. Nevertheless, the stability of the biceps anchor must be restored, thus stabilizing not only the biceps anchor, but the ligaments, the superior, the middle glenohumeral ligament, re-establishing the stabilizing effect of the biceps tendon to the shoulder joint. The traditional techniques are not, strangling again the labrum, are not the best, generally speaking, because you are at risk of stiffness. And this is the technique that these are on the left, the original picture of my paper that is in the ESCA journal. And here is a little video that is showing you what I mean with this. I use two portals only for the slap lesion. I come from posterior aspect of the biceps, and I go placing my anchor, whatever it is. It is a double loaded anchor usually. But the idea that I use here, let's say that it is a tape A, sorry. I use the Spectrum, my favorite for the labral repair. I make my first step with the blue suture in this case. I retrieve it, and then I repeat exactly the same step with my same color suture. So I have a mattress, and you see that I'm going slightly posterior in order to make my repair. I retrieve the other limb of the same suture. So I'm creating a mattress configuration that is compressing the capsule, the posterior superior capsule, over, let's say, the tubercle, or the same area. And then I tie my mattress suture superior posterior, but I do not strangle the labrum. Then I have an extra suture that I can use to repeat the same step. If I have a tape A, I can fix the anterior labrum with a simple stitch. I can play with this, but it is an added step that is not treating anymore the slap. In this case, you are stabilizing the attachment of the capsule and the ligament over the anterior superior labrum. So this is the idea. Just repair over the tubercle our capsule and structure, and then eventually stabilize the labrum if you have an associated tear somewhere else. So this is the drawing, the simulation, and this is the real life. Exactly the same scenario. This is the supratubercle reattachment. And you see, always check it if it is a real slap or not. And you can understand this after debriding this, because if you do not check if you have some bony exposure, you may overtreat. And you see that here, it is a real detachment. Please always debride it and make your repair. Again, now I am preparing, I use now all suture anchors, I also already mentioned, very little invasive. This is the one-step ConMed why not flex. It is just very, very simple. You just push it in, and you don't need to do anything. Just push the anchor in and then remove the inserter after drilling a little tiny hole that is 1.8 hole. You don't need to make any further step in order to have your suture anchor into position with two double suture. In this case, they were tape. I don't know if there is any difference with tape or typical. You see here the anchor itself. If tape or a typical suture make any difference, I don't know. You simply push this in, introduce it completely, and when you're happy, you simply remove the introducer. Easy, quick. It is called one step. I don't know if it is available also in India, but I like it. It is very, very easy and quick. When you remove the inserter, you simply pull it away. You're ready to go. You double check, folding the little ball of suture in the bone. That is, of course, important in order to lock your implant. And once you remove your introducer, You go posterior with a single portal. You see the tape suture here. You remove your guide, and you're ready to make your repair. You have two loaded. And here comes the spectrum. We are posterior now. And I take the capsule, not the labrum. I come from bottom to top. Step out quite posterior here, as you will see. And then, like all of us, I'm using a monofilament as a shuttle. And you notice it is quite posterior. Exactly the anatomy that Sagar was describing. I retrieve by suture through the single portal. Of course, since I have four limbs there, I need to use my suture retriever in order to prevent any possible tangling. I retrieve it. I come posterior. Here is my PDS in this case. I noticed a friend previously was showing Nagray probably a proline, whatever you do. And then I repeat exactly the same step for the black and white suture, coming from posterior over the capsule. So watching here, you see my spectrum here that is coming and making my mattress to place this in position, coming out, retrieving with my suture retriever the other black and white limb, retrieving this through the same portal. Again, you can use two portals. It is nothing relevant. It is just a little more challenging the suture management if you use two portals only, but it is not really changing the principle of the treatment. Do whatever you want, and not relevant. I retrieve my second limb of the black and white, and now I have a mattress that is just posterior over the capsule, and I tie the knot. And you see that I like to have the superior labrum that is free. There is the knot. So I did not strangle the labrum at all. Here is the repair, and then it is then available. I make a cut that is short with my suture cutter, simple step. And again, you see how compressed posterior medial over the tubercle. Then you can use the second suture if you want to repeat this, to repair the anterior superior or whatever you want. But this is the idea that is behind it. So as a conclusion, SLAP lesion is an anatomical lesion that can be clinically significant, especially in the active population, should be treated in selected cases. There are many options to treat it. Stiffness is something that is always behind the corner, around the corner. Nobody mentioned this, but posterior labral tear are often associated with paralabral cysts. So repairing this can be important, but most of all, follow the anatomy and the biomechanics for the treatment approach. Because when we treat a SLAP, we do not treat something that is fancy in our fantasy. We are treating very often different conditions biomechanically, anatomically, and functional related to the patient symptoms and demands. So don't be focused on a single possible approach. And again, for me, the diagnosis, the full diagnosis, is very often intraoperative. This is just a little memo because these are the most important event probably in the near future. This is our friend COVID. We postponed our SECEC, European Shoulder and Elbow, a very good scientific society. I was the past president in 2000 something. And in Poznan, if you are interested, I canceled my SMILE course with live surgery. It is a very great fun with a lot of good friends, Pascal and people from the US and everything from 2001 to 2002. But most of all, the big Congress, the International Congress of Shoulder and Elbow in Rome that was scheduled for 2022, we decided to postpone 2023 because I want to do this in person with all the friends discussing and having a good time together. So Roshan, thank you again for the invitation and happy to discuss, but probably this was the conclusion of the beautiful introduction from Sagar about the anatomy and biomechanics, because there were so many, and we didn't talk together before, there were so many things running together and merging. And also with Nagrai showing these different possible techniques, with this conclusion that is probably telling us how we should approach this superior labral tear associated with our biomechanical condition. So thank you all of you for the patient to listen to. Thank you.
Thank you, Alex. That was a wonderful revisiting of the slap tear. I think the paper is open for discussion. We had few questions, one from Nagaraj, one from Sibin, and one from Bhupesh. Please go ahead.
Yeah, I'm Dr. Bhupesh. A fantastic presentation, Dr. Alex. Thank you for enlightening us. This question that I have is for all three speakers, because all three of you touched in this. For clarity purposes, I would like to know. I generally, like how Dr. Nagaraj showed, I will always go and prepare the bed before I place the anchor, because although we know that the blood supply is not from the bone itself, we need a good healing bed for adventitious blood supply to kind of hold it together. But for everybody to understand, please give us your thoughts on this. Is it very important to go and prepare the bed as we do in regular bankarts, or is it something that we overdo? What is your take on this? To all three speakers, please. Thank you.
So I start. I am the senior one, just to start. Well, number one, I totally agree with Sagar, and it was a big study by Cooper, 1950 something, about this poor blood supply to the superior labrum. So we knew that. And bone is not that much relevant in that specific area, but I personally like to clean it in order to see the lesion, because I showed you, it was very clear. At the beginning, I couldn't tell you if it was a real avulsion or not. So I like to debride it in order to understand very well what is going on. And anyways, although it is not the most important, I like always to have some exposed bone in that area. But it is crucial to make a substantial debridement to understand if it is a real or a fake slap lesion.
Bhupesh, I'll go next. I think Dr. Kastania has nailed it. We know about the anatomy, but when we are in there, we want to make all the efforts that we create a nice, low tension, healed environment. And therefore, the traditional liberator would not have that much amount of role as much as you have in the anterior inferior. It is just to create a area for your shaver to come in. The curette, which I use, is also just to debride some amount of subchondral bone so that there is a bleeding surface. But I think what has really helped is these low profile shaver blades, the torpedo and the flyer blades. They nicely go into that area and you get a very nice rough surface. I think one important point we need to touch here, and Dr. Kastania can either accept or refute this, but unlike in the Bankart repair, where you come on the face of the glenoid, I like to go slightly on the subchondral surface, because we don't want to have that bumper effect at all, according to me, because that adds to some amount of over tensioning. I like to be just a bit subchondral, and these are the tips to have a stable repair.
Thank you. Thank you. I think
there is a question from Sibin.
Yeah, to Dr. Alex and Dr. Nagaraj. Excellent talk, and really got some new information. So one of the common associations, as you mentioned, with SLAP is paralabral cyst. So do you always go and decompress, or is there a role of just repairing the SLAP, and is there a situation? So what is your take on it?
Well, I'll say in the literature, you have two basic principles. The big group from Norway, they published a few years ago that simply repair the labrum and the cyst will resorb. The principle is this: why we have this paralabral cyst? Because you have this
trapdoor.
Hello? You have this fluid coming from inside the joint and going there with this myxoid degeneration of the tissue and then making this reaction, and you should repair it. However, a few years later, some other author said, well, you have a better outcome if you even evacuate the cyst. Let's say that if the cyst is quite a big one, I like to evacuate it. It is not difficult. I mean, you're there. You must simply be careful not to be tempted to go too far medial because you have the nerve there. And we like to decompress it simply because it is compressing the nerve. So if it is a big one, I like to evacuate it. But sometimes if you repair it simply, it is clearly reported in the literature, this will resorb anyways.
So just a point here. I agree with almost everything what Dr. Castagna mentioned, but these are two different patients. A patient who presents to you with pain and you see a spinoglenoid notch cyst. A paralabral cyst is not comprising every pathology that Dr. Castagna mentioned. What is probably right terminology is a spinoglenoid notch cyst. So paralabral cyst, which has now become so big that it has encroached into the spinoglenoid notch and pressing on the descending branch of the suprascapular nerve. No question about it. You're going to go and decompress it because that's your pathology, primary pathology. You would close the repair because then you don't want the trapdoor mechanism to work against you. It's very uncommon for you to decide for a small paralabral cyst that you want to actually operate on these patients. So that's the point I wanted to mention. Yeah.
Sir, okay. I have one question for Professor Alex and all the panelists here. Do we have any specific position of the limb when we are tightening the sutures for the slab? Do we do it in lateral position always, or maybe may it be a V chair position, but do you want your shoulder to be in specific attitude when you tighten at least the posterior part of the slab?
Well, not really my case. I do in lateral decubitus. That is my favorite position for any kind of instability. And I don't see any possible variation for this anatomical repair of the supraglenoid reattachment. So it is not changing that much for me. I think that you simply should do what makes you feel confident and in control.
Dr. Nicholas is waiting. Yeah, Dr. Nicholas, sir.
Professor Alex?
Yes.
Thank you for a nice enlightening lecture. In the paralabral cyst, the labrum is often, that part is covered by the capsule and we have to open that to decompress it. That means we are creating the tear and then we are told to suture. Some keep it open, some keep it, some suture. Does the suturing is the same as you showed of labral tears, or this suturing is different, where you also enclose the labral tissue?
Well, first of all, you can have the paralabral cyst in different position, but roughly saying that I have served one anterior inferior in a professional goalkeeper, but one in my life. But let's say that 90% it is just posterior superior that is going then to the glenoid notch and then compressing the nerve. It is the most common site in my personal experience and also in the literature. So this is a little different that it is not exactly a slap lesion. It is a tear that is posterior superior, and I repair this if it is exactly in this area, let's say 11 o'clock or so. I repair this with the Wilmington portal and I make a formal labral repair. I need to seal that. I mean, I don't want to have the synovial fluid going out again and create again this myxoid degeneration of the tissue and so on and so on. So, but it is not exactly a slap, but it is an evolution. Again, when you say slap, we mention many different possible conditions.
Dr. Alex, this is a small video. If you can see it here, I think we are unable to run it. Just a minute.
You see here, we have an anterior superior labral detachment.
So it is a very, very small anterior, but it's not going very posterior.
No, exactly. This is not a slap. To me, it is an anterior superior tear, The problem here is the middle glenohumeral ligament.
Yes.
I would stabilize this shoulder because this is painful in the mid-range of AB adduction and external rotation.
Okay.
And I assume. And I would simply stabilize anteriorly, let's say at 1 o'clock.
Okay.
Not the labrum itself, but let's say the middle glenohumeral ligament. It is exactly what I said before. When I was mentioning about this possible painful shoulder with this anterior superior isolated tear. You remember, I published this in arthroscopy.
Okay.
And these are painful shoulders, and you simply stabilize the middle glenohumeral ligament, and that's it. It is not a slap, but still we are tempted to call it a slap with an anterior component. Again, we use one word that is not defining the 100 possible condition that we can find in the shoulder.
Anybody with a difference of opinion for this management of this case? If you can see this video.
Can I come in?
Yes, please.
Yes, Nagaraj. So it's actually a question which I had reserved for Dr. Castagna also. I agree that for a thrower and for a patient who is primarily a painful shoulder in an active individual, but we see this area quite often having some amount of detachment, and we are always worried about incarcerating the coracohumeral ligament, and we find that these patients are stiff and painful for quite some time. So as far as I am concerned, I'm very careful in putting a stitch in that area. So haven't you had that experience that these patients remain painful for a prolonged duration of time because of coracohumeral ligament getting pinched, so to say?
Well, you should not, I mean, the coracohumeral ligament, if you repair just that area for the anterior superior labrum, is not involved. Anatomically, it is not there. It is very much more, let's say, superior anterior compared to this. So I don't see any risk for this. I agree that this condition that was shown now in this video, it is related to an athletic person, because otherwise you don't have any reason to go for
he was a professional boxer who didn't respond to any of the kind of physiotherapy. I almost waited for a 1-year rehab, and then ultimately I decided to do an arthroscopy to find out what exactly is wrong, and I didn't do anything for that. I just left it as it is, and just a simple debridement, and that patient eventually became better with second round of rehabilitation. I think it was more of a psychological disease, because somebody has already diagnosed it as a slap tear on MRI, and patient carried that, and with just a debridement, as we do it in knee arthroscopy, just a small debridement, and then patient is absolutely fine. I didn't do any anchor repair for this patient.
Yeah, but it is different from a thrower. A thrower can be...
It's a different from thrower. So for throwers, I'll share you one case. This is open for discussion. Now we are discussing the cases. Anybody can come at any time. This is 23-year-old male overhand thrower. He has increasing pain after throwing and loss of velocity and accuracy. You know, the cricket is a very popular game in India, and we land up in this kind of throwing action. Literal pitching, and intermittent rehabilitation has never worked for almost more than 3 months. And as usual, the MRI was inconclusive, the clinical diagnosis were inconclusive, and I decided to go ahead with the arthroscopy. So can you see it now on your screen?
Yes.
Yeah, we can see it.
Yes, we can.
Yeah, and this is demonstrable peel off. If you can reasonably see it, not very best what we can demonstrate in beach chair. I do my arthroscopy in lateral positions, but still I could demonstrate a peel off. So, Alex, how do you proceed?
Well, this is a very, very typical posterior superior impingement peel off, whatever you want to call it. Now, the first question that I have for this patient, any restriction of the internal rotation?
He did had a restriction of internal rotation in this patient.
Because this is the most common cause of this condition. Okay. So this patient, first of all, should be treated very much with rehabilitation to recover internal rotation. Otherwise, you treat this, and I don't fix that labrum. I simply debride it. I leave alone the cuff also, because if you don't, This is a case where you can induce stiffness, a bad one. Going back to Nagre's comment, if you even repair that little tear of the cuff, should say the capsule, and the posterior labrum, if you are too aggressive, you may lead this patient to very unhappiness. Recovering internal rotation should be crucial, and eventually just the breathing, and that's it. But usually with a good physio, they can be fixed without any surgery.
Okay. Rajkumar, you have any difference of opinion with Alex, Swanendu, Rajkumar?
No, but I would like to add a comment to what Dr. Alex has told. Do these people have different clinical findings before we proceed to do these kind of a procedures on them where we land up with stiffness? Do the arms, have a different range of movement, or clinically we can pick it up saying that yes, these are the individuals who can, really benefit from these kind of a procedure, or is there any clinical point?
Yes, you can pick up from your clinical point is that if your internal rotation deficit is more than 15 degree or 20 degree, then you know from your GIRD that this guy is probably not been going to improve even if you tie your the posterior capsular. So if your GIRD is more than 15 degree, you have to be overcautious. Am I correct, Alex?
Alex, if this patient would have been a badminton player, a tennis player in Italy, Italy, the tennis is very popular. So will you like to offer?
And I treated many professionals, and the shoulder you have seen before is a professional playing ATP, very high ranked, an Italian player that is playing currently. So this is typical, because they overuse the shoulder there. But in case of a tennis player, in this case, first of all, again, internal rotation is crucial. In this specific case that is totally different of the one I showed before, eventually I would simply debride the tissue. That's it. Of course, I don't have all the complete picture of the patient and all the things, and exactly I would do simply this, never fix this. This is not a real pasta lesion. It is simply a little stretch of the capsule in the articular side, because the risk of some stiff, exactly, and you fixed a little bit, but not too much, just going there. Let me see. Yeah,
Same way as you described.
Yeah, but you are a little more posterior.
Okay.
Here it is crucial. It is a little different. It's crucial to just bite the labrum and not the capsule, as you did. If I see well, it is just the labrum.
Alex, I've got a very simple, probably might look very stupid, but thing is that what is your indication of doing MR arthrography in your clinical practice? Alex, you are muted. Alex, you are muted.
No, I could not hear your question because the voice was gone. Can you repeat it?
My question is, what is your clinical indication, or the when you advise basically the MR arthrogram?
Well, these are the good cases for the MR arthrogram, because you really need some fluid there to see these minimal tears, and you should have also a good quality equipment, at least 1.5 Tesla, because again, this kind of tear, they can be even not diagnosed by imaging.
I want to ask you what is your clinical test when you suspect, because everybody is not going to the MR arthrogram. How you decide this guy is for the MR arthrogram?
Well, MR arthrogram is a tool that you have in your hands, like the clinical exam and the history. So I ask for if it is the question, if I understood well, I do an MRI arthrogram when I have a person, probably an athlete, that is reporting me pain by serving or playing cricket or so, with clinical presentation of this pain and clicking in the joint. He did a good rehabilitation and is not happy. I do my test about instability, all the tests that we discussed before, but I'm never sure. My exam in that case is MRI arthrogram. It is an extra tool that I do. Okay,
Okay,
this is the
understood.
process.
Okay, understood. Thank you.
Question from Dr.
Roshan.
Yes, Dr. Narvekar, yes. Can you start your video?
Can I ask
Yes,
Alex?
Yes.
The last case that he showed, is there any role for a posterior capsular release in these patients?
Posterior capsular release, yes.
Yes, they have a GERD type thing.
Of the internal rotation?
Yes.
Yes, I rarely, but I did it. In those
So if
cases,
you were to
not responding to physical therapy and very stiff and so on and so on, I did it. Not many, but I did.
If you see this video, once we had done a repair, I did a small capsulotomy. Alex?
Yeah. Good idea.
Do you agree with this concept?
Well, I mean, about this case, I would be a little scary about fixing too much the posterior labrum and then created some stiffness. So releasing a little bit can be an idea. Because my option, again, I'm commenting just a little video is not enough. You know the patient.
Yes.
So theoretically, I would simply debride it. But again, if you did it, and then you stabilized also, you see that you are over the tubercle there, it's a good idea to create some release in order to prevent some stiffness.
Dr. Narvekar, do you do this kind of capsulotomies post-surgery, especially in SLAP?
No, I don't. After I changed my technique as I showed before.
Okay. Dr. Abhay, do you do capsulotomies post fixation of superior labrum?
Yeah, the one that you have shown just now, where there is a sort of a peel back where you're forced to eventually operate on that posterior superior labrum, I think it's a very good idea to do a capsular release, because then you don't have that stiffness and problem of pain.
Yeah.
May I go with the question?
Yes, please.
So Alex, if you are operating a patient who is an overhead athlete, and while doing SLAP, you found that the biceps is not healthy, so would you do a biceps tenodesis along with your labrum repair, or would you leave the labrum alone? Young patient.
Again, the voice was missing in the first part of the question. Can you repeat? Sorry, but...
So once we are operating a young patient with for the SLAP repair, and you found that the biceps is not healthy, so would you do a biceps tenodesis and labral repair both, or just a tenodesis?
Well, not healthy is a definition that is hard to define. If I can preserve the biceps, I like to preserve it in a young boy or girl. But if it is not healthy at all, I may do a tenodesis. This happened to me in some professional gymnasts. They are young, 16, 17, 18 years, with terrible activity and a bad biceps. I fixed the labrum and I tenodise the biceps. But it is not a routine procedure. And if I can preserve the biceps, I do that.
Okay, thank you.
Okay, Rajkumar?
Yes, continuing with the same question as Sheetal has posed you. In this young individual, if you want to do a tenodesis, which will be your site of tenodesis? In the groove, in the joint, or subpec?
Well, again, this is very much focused on the patient.
Yep.
Let's go with a grading of it. If you have a bodybuilder with a bad biceps, very inflamed, I do the sub-pec with a mini open as described by Negre, very similar to that, because I like to take the biceps out of the groove, because sometimes you make your tenodesis and the groove is the painful part. When you do a total shoulder replacement, hello? When you do a total shoulder replacement, you often find this bicep that is glued in the groove. In the very senior population, I simply do a tenotomy, and that's it. in the average condition, if I have an associated rotator cuff tear, I use the sutures of the anterior sutures of my repair in order to stabilize at the entrance of the groove with an anchor my biceps. So it is very much focused on the age, function of demand, physical structure of the patient, ranging from open subpec, uncommon, but in the young, very active bodybuilders, to tenotomy in the very senior patient. Depends very much on the patient.
Alex.
Thank you, Alex. There is a video that is playing for you to view and comment, I think. Roshan, come in.
Yeah. Alex, can you see this video? The bicep lesion is going high, and there is a pasta lesion, a partial articular surface tendon tear. So how do you address this in a young?
How old is the patient? What is his activity?
32-year-old male who had a consistent pain with this severe inability to throw the ball.
Well, you need to understand better. First of all, you need to remove that tear. This is a type 4, let's say, slap lesion. So I need to remove all this tear of the labrum. Then I need to debride perfectly the tissue there, because it is not the pasta lesion that is concerning me, but the problem can be in the pulley. So if I have a failure in the pulley, then I need to do a tenodesis. If not, you may simply debride it, remove the torn labrum, and clean all the tissue and leave it alone. But crucial in this case, for the pain, if you have this cuff problem, is if the pulley is okay or not. Because if the pulley is gone for some reason, the superior glenohumeral ligament or the posterior aspect, I'm not confident to make any repair there, and I do a tenodesis. So again, you need to clean and see. What I said, arthroscopy is the best tool to see the details that no imaging can show you.
Yeah. So if there are no questions, I think that was a wonderful.
One last question, Roshan.
Yes, last question. Rajkumar, yes, please go ahead.
Professor, I agree with you that you do mattress suturing for all your slap repairs. Is that the vascularity that is directing you to do that, or your results of doing only a mattress suturing for slap repairs is good?
Well, I described the mental itinerary that was leading me to this, from the strangling to different techniques, the Wilmington portals, and so on and so on. Then I finally understood that the supraglenoid tubercle repair is most anatomical, is preventing tension, and that's the best blood supply, forgetting about the free edge of the labrum in the joint. So putting all this together led me to this choice. And honestly, I should say my patient, they were happy.
Okay.
Thank you. Thank you very much, sir.
Thank you very much, Dr. Alessandro Castana, for a wonderful session, the wonderful discussion and wonderful suggestions on different topics. SLAP has always been a controversial from day one. And I think the controversy will persist so that we can meet very often and we can discuss with you how the things are changing. And we have been seeing that changes in the history and historical changes, may it is a diagnosis, may it is the treatment and surgical options for SLAP, has kept on changing in last 10 years very rapidly. And I'm very sure another 5 years down the line, when we meet together, we'll have a different concept for the SLAP. So with this, I would like to thank all the panelists and especially Dr. Alessandro Castana, who took out his own time and came for us. Thanks, Dr. Alessandro Castana. Thank you very much from the Indian Fraternity of Arthroscopy and Arthroscopy Study Group of India.
Thank you.
Thank you, everyone. Thank you, and I hope to see you in person sooner or later. Okay.
One thing on a lighter note that I want to mention, Roshan, if you allow me.
Yeah, Sandeep, you can go off live. Yes.
I want to congratulate the young Italian brigade that is playing in French Open.
Okay.
Thank you. Thank you.
They are doing really well, Musetti and Skinner, and I'm sure they will give a tough time for Nadal and the likes of Federer and Djokovic.
They have tough challenge, but thank you for this comment. And 2 of the 3 that are there,
yep,
I follow them
yes.
for the shoulder. 2 out of 3.
So we wish you upfront all the very best.
Thank you. Thank you, Alex.
Thank you. Ciao, ciao.
Ciao, ciao. Bye, bye.
Bye bye.
Okay. Thanks, Rajkumar. Thanks, Sheetal.
Bye bye.
Thanks, Satish. Bye. Satish, you can stop off on live if possible. It's Sandeep, can you hear me? Sandeep? Dr. Biraris? Sandeep Biraris, doctor? I think we can't hear him. You need to talk to him and call him. And so I think it was a good session overall.
Very nice, Roshan. It was really nice, and he's a stalwart and one of the very skillful surgeons.
Yeah.
Very skillful and very learned.
Yes.
Very nice invitation actually.
Thanks, Nagaraj. Thanks for your talks and discussions.
Thank you, Rajkumar sir. Good luck to you.
Thank you. ಹೇಳ್ರಿ ಎಲ್ಲರಿ ಆಯ್ತಾ?
Don't.
Thank you very much.
Live stop.